We are ready. Okay. How are you? Good afternoon. Do you hear us? Okay. Okay, the voice is a little bit low. So now today I would like to thank again Abid and Nawaf, Adil, all the team in King Fahd Medical City for the effort. Today I have Professor Said Ghnoeum from Dammam with me. We have a case of a female with Achalasia type 2, and she had previous poem 7 months ago, but still the patient had elevation of the Eckerd score and still symptomatic. And I think the new manometry is showing a little bit elevation in the IRB pressure. So I will go back from the tunnel. We did the incision, and I would like to show you the site of the previous poem. If you look here at 6 o'clock, this is mostly the site of the clipping. You see it clearly, all right? So yes, the voice is a little bit far. ممكن نعلي الصوت شوية? The endoscopic picture is not existing? Okay, good. You see here, this is the site of the previous poem. It's posterior approach.
It's the entry, I think this is the entry site.
This is the entry of the previous poem. You see it, right?
Clear.
Okay, great. Now the sound is good. And if you
So
go...
Amr, tell us how many percentage points fail, and you have to do it again. And what was the cause of failure? You didn't do a good myotomy first? What is the cause of failure?
Repeating the poem, I would say it's successful in 97-95% of all cases with achalasia. And the causes of failure of poem could occur if the tunnel is not reaching or passing the G junction. If you look here, still the patient, there is a ring of contraction here. You see, I couldn't pass with the cap, you see? So I tried to change the approach from posterior approach, which has been done before for the posterior poem 7 months ago, and I make my incision anteriorly here. So I'm going at, if you look here, this is, yes please.
In case of redo, you will go different direction. It will be easier than the first one.
Yes, I would change the place of the previous intervention and the fibrosis, and go for a safer place. If you look here, this is the impression at 6 o'clock of the spine. And at 7 o'clock, we have to go for the posterior approach of poem. And we could go in the anterior approach at 2 o'clock or 11 o'clock. So I did my incision after discussion with Dr. Said to go for incision at 2 o'clock. And I think now we are approaching the G junction. And this is the cardia. So I go back to the tunnel.
And I think, Dr. Amr, now the cardia is opened. In comparison to the index endoscopy, we cannot pass easily to the stomach. So the previous myotomy is not complete myotomy, I think.
This could be one of the causes that the previous myotomy was not extending or crossing the G junction. So if you look here, needle out please. I'm working with a hybrid knife from Irby, traditional one, T-type. And I will inject here at the right side. I have to get a good pleep, blue one.
So, Amr, if it is incomplete myotomy, can I sue the first doctor?
No. My team is laughing for your joke.
Can you hear me? This is
yes.
Moment over here. Very nice demonstration there.
Hi, Moment. How are you?
I'll answer Dr. Hamad's question. At least our protocol in those. I was not sure how, like what kind of workup was done after the patient came back with symptoms, but we routinely do an endo flip. So for those patients who come back with symptoms after achalasia treatment, we do endoflip. And what endoflip does is that basically it measures an index, a distensibility index at the GE junction. And if that DI, or distensibility index, is below 2, that basically means that the myotomy was ineffective, and now we have an evidence to go and sue that doctor if you want to, don't do that.
No.
But you have an evidence that you have a very low distensibility, so that the previous intervention, whether it was foam or it was Heller's myotomy, is ineffective. And it's also a good predictor of response for repeat foam or repeat intervention. Again, that they can go for Heller's if they have a posterior foam, for example. But that's a good predictor for response. But if that DI is high, is like 4 or 5, means basically there is no resistance at the GE junction, and really the likelihood of patients benefiting from any repeat intervention that's targeting the LES is very low, and that means that that first doctor did a very good job. But the problem in achalasia, as you know, is that there is another element where the peristalsis of the esophagus is not working. So we cannot make the esophagus contract better, but we can make it empty better by targeting the LES.
And especially again, thanks Momin, the patients still have a high Eckert score of 7 or something. It's still above 3, and this means most probably we need to extend our myotomy in this case.
I think, Dr. Amr, another problem may be when we do dissection, sometimes there's a tight cardia, and sometimes some endoscopists dissect through the muscle, and so some muscle fiber will be attached to the submucosa.
This is true.
So sometimes
I totally agree with you, Dr. Said, yes. Sometimes the incomplete myotomy for the J junction of the cardia could be a reason behind that. And that's why we have to extend that. And I think we published a paper, me and my friend Ahmed Madkour, for the anatomical landmark for assessing during the procedure real time, the passing the GE junction and see the peritoneum as part of reaching the gastric side sufficiently to do complete myotomy.
And I think in our case now you are approaching the cardia now, Dr.
This is the G junction, and I feel that the current is not that effective, but I'm trying to put it very cautiously, because here I need to inject to separate, but there is a fibrosis here.
Yes.
You see?
Dr. Amro, do you need to go 2 cm below the G junction?
I need to go 2 centimeters below G junction in the gastric side.
Dr. Amro,
Yes, please.
the success rate last time we do similar to the first time? I mean, does it carry the success rate, same success rate and complication rate?
That's why I changed the approach, I mean, in a different way. So I'm working in a naive tunnel, and I think it would be, in those cases, if this is a true achalasia, yes. In most of cases, it will be more effective. Now I am at the G junction. You could see here at the 3 o'clock, the palacidial vessel, which is a landmark that we have started to go in the gastric side. I'm dissecting with the precise sect mode.
And here the tunnel now appears much more wide, Dr. Amr.
Yes, we are. Dr. Said is telling me that the tunnel is getting wider, and this means we are diving deep in ocean view in the gastric side after repeating the injection. Of course, I have to be cautious here from the gastric vessels, perforators that might occur in our pathway or tunnel during passing this, and I think there is a couple of vessels here. Now I'm here in the gastric side. You see, at the right side, this is the muscle layer. At the left side, this is the mucosa. This is the mucosa at the left, and this is the muscle at the right. And now I'm passing the cardia, trying to inject here. Okay. give some air and good exposure, and dissecting with the coagulation thoroughly, as we
So,
see.
Amr, when you finish the myotomy and you go out, how do you relay the information to the patient and the family? We did, it was not complete the first time, and we completed this time, or how do you relay the information?
This is just assumption. What we are saying now is just assumption that it could be like that.
Okay.
So we are just trying to see what is the reason behind that this patient did not get the benefit from the previous point. Okay, see you later. We will go to the other room. I think they are calling for extending down 2 centimeters. What's your opinion, Dr. Saeed? We
I
will
think-
start to do the myotomy.
Yes, I think to start the myotomy to release the tension at the cardia, and if we want to extend more, we can do after that.
Okay, good. So we will go in another position. I will try here, needle out please, to do some coagulation for overlying vessels.
So you prefer to do full myotomy from the start, Dr. Amr, or to do selective and then full myotomy at the cardia?
I would prefer to do full myotomy because we are like few centimeter above the G junction. We need to make like an effective one.
So, Amr, post-poem order, what are the orders post-poem regarding liquid and MPO and fluid and diet?
The patient is left for 24 hours to 48 hours MBO, and then start to drink soft, clear fluids. And when everything is good and the patient is stable, then you could start soft diet for 1 week and then regular diet. I'm trying here to do some selective cutting to see or discriminate between the longitudinal and circular muscle. As you see here.
You need to do, let's say, water soluble contrast, just to see the esophagus, the achalasia, the shape, or anything.
No mandatory for a contrast enhanced injection, I mean swallow or barium meal for those patients, unless the patient is stable and normal. This is a full thickness myotomy. I'm trying to be cautious during the final cuts. Now, as you see here, this is the full thickness. Okay, going back again. This is the longitudinal muscle, as you see. And this is the full thickness down. And what we see now is the anterior mediastinum. I'm trying to hook my needle and do the cut in a full thickness manner, as you see here. You see?
Yes.
Trying to hook, look for any vessel exists in my way.
And usually you start with coagulation, Dr. Amr, and then with cut.
Yes, we do this. The muscle is also thin. It's not that thick. That's why I'm trying to be very, very cautious. You see here now this is the fold and this is the diaphragm. So I'm hooking the needle behind the muscle, push it down and do the cut, and be cautious from the contralateral wall. You see now this is the peritoneum. When I reach the peritoneum means that we have a good depth of the incision. Yes, I have the mediastinum in front of me. There is vessel here at the left side, you see it. I'm trying to... Yes, the voice is far a little bit.
So the question is about any special precautions for the anterior compared to the posterior approach?
It's almost the same. There is no special thing that's different. As you see here now, it's getting wider between both of them. Just the orientation, I have the muscle above me and the mucosa below me, and the cutting steps, I have to be cautious not to hit the mucosal side. I would like, this is the peritoneal side here, as you see. I am trying to do some coagulation at this space.
Okay.
Okay. So now I think we have full thickness myotomy. I think this is very, very wide. I reach to the base of the tunnel. Okay, good.
We have 3 minutes more.
So we here, as you see, this is all adventitia. This is the diaphragm, and this is the gastric side. There is some intervening vessels behind that. I reach to the base here. It's very, very wide. The mucosa at 6 o'clock, and the muscles here. This is the longitudinal muscle. So this is, I think, very enough depth, few millimeters. What do you think, Dr. Said?
I think 2 to 3 millimeter beyond the cardiac. I think it's enough.
Okay, good. There is some vessels here. I try to coagulate in order to avoid any delayed bleeding.
I think it's enough in the stomach.
As you see now, securing this, especially if the patient, not in our case, needs to start anticoagulation or something like that. So now, I think
Ghnoeum.
this is enough. And if you go here, this is the incision, and this is the anterior part, and this is the posterior with the previous incision. And if you go here for the cardia, I think it's very wide compared to the previous examination at the baseline. I think we are done, and the abdomen is lax. We have a peak pressure of 22, not that high. It's good. So I make my suction, and then I will apply the hemoclip to close my tunnel. I need clips, please. Okay. 11, okay.
نعمل ريفلكشن كده. هذا راح نواف بس نواف عايز يكستند شوية.
عايز تكسن؟
even the cardia يعني في الأول احنا الكارديا ما كانتش مفتوحة كده خالص يعني.
So the initial clap is very, very important.
Okay.
What do you do more to make sure that I will not do you?
Any technique, any technique has a degree of a failure rate. I would say that poem in Achalasia is rising and improving. Improving the technique and has a good outcome. If the patient had repeated the examination, the procedure twicely, and still have some sort of achalasia, dysphagia, I agree with Dr. Moment to go further for further assessment to check the motility, and if this is symptoms relating to the achalasia or something else, we should to repeat this in another manner like in surgery. So I am satisfied with this extension. We have like 2 to 3 centimeters. The patient had previous myotomy posterior and now it's anterior. I hope this will be helpful for her. If not, then we have to dig deeper and assess further. Open. Okay. Close. Fire.
provide medication.
Could you repeat the question again? I'm sorry.
So if you admit all patients,
Yes.
point,
Yes.
or the selective visit, like you charge them same day if the point is uncomplicated.
If the point is, I don't hear. Huh?
Admit,
I have to keep the patient for the first 24 to 48 hours. I have to assess the respiration, the peak pressure. I mean, I'm sorry, the tachycardia, the blood pressure. There's no fever. All these things are very important before discharging the patient. And if they are fine with good CPC during the first CRP during the first 24 hours, I will make the patient start to take the first sips of water, clear fluid. After 24 hours, if it is fine, then I could be brave enough to discharge my patient. Am I answered your question or?
Yeah.
Okay, great. Okay. So we will move to another room. Recalling. Thank you.